but I'd like to introduce our next speaker. You want to have Jennifer come up on the stage. So Jennifer is a genetic counselor now in the UNC Division of Genetics Metabolism. She had previously been at Duke, came over to UNC, and she's heavily involved in our newborn screening follow-up at UNC. Jennifer.
Thank you, Dr. Munzer. Thank you all so much. As Dr. Munzer mentioned, I am a genetic counselor in UNC's Division of Genetics and Metabolism. And I do want to give a hat tip to the person who created these slides. Kristen Kleinert, who is the genetic counselor for the MPS Center, is the person who created these magnificent slides. And she's unavailable to give the talk today, so I'm giving in her stead. But any of the amazing graphics you see are all her and not me. So the focus of today's talk, oh, and I want to say I have no disclosures. So today during the talk, we're going to review the newborn screening system in the United States, describe newborn screening specifically for MPS, and review some of the challenges of newborn screening for MPS, as well as identify some of the future opportunities for newborn screening for MPS in general. So newborn screening, what is it and why do we have it? So this is a little historical context. Newborn screening is a public health program that started in the United States in the 1960s, and it is an aim is to identify children to allow early intervention that allows you to intervene. So you're often identifying children before they have any symptoms of the diagnosis of concern. That's the goal. So it's public health. It is designed to improve and protect the health of communities and populations. In the United States, newborn screening is an opt-out program, meaning that you need to, in most states, explicitly say you do not want to participate in newborn screening. Otherwise, it will happen at the hospital where you gave birth, or if you did not give birth at a hospital, at your pediatrician's office. Screening means that it is not a diagnostic test. The way I often describe screening to families is that it waves a little flag saying, hey, pay more attention to me. So it detects potential diagnoses, but it is not a diagnostic test. It just identifies infants who may need further follow-up. So if we think about the difference between a diagnostic test and a screening test, a diagnostic test happens when an individual is having symptoms. The target is the individual itself, and the result gives you a yes/no answer. And there can be cost associated with that. And often the method can be invasive, including a needle stick, a venipuncture, where you take blood from a vein. In a screening test, your timing is infants, usually within the first 24 to 48 hours of life. And your target is a population. The results indicate that an infant may need further follow-up, but is not considered diagnostic. And the cost is typically wrapped into newborn care. So it's not something that most families would even notice on their bill associated with the birth of their child. Both diagnostic and screening tests identify health conditions that require medical attention. The goal of newborn screening is to save lives and/or improve the quality of people's lives. So we want to be able to intervene and make a difference for babies by giving them information that would not be obvious at birth. For some perspective, this is actually from my favorite article about newborn screening. I know it's kind of funny to have a favorite article, but it talks about the evolution of newborn screening. On the left here, you see a boy who was diagnosed before the advent of newborn screening, and he has a diagnosis called PKU, so he does not have MPS. On the other side, you see his younger sister. His younger sister, clearly sitting upright, smiling at the camera, she received treatment early. And the reason she was identified as having this diagnosis is because of her brother. The family knew to look for the diagnosis in the sister after she was born. And families, obviously, and clinicians obviously looked at this picture and said, Why do we have to have a child who doesn't have treatment when we can have both children be sitting up and doing well? And so that's where newborn screening evolved, identifying children before they had symptoms. So as I mentioned, in the 1960s, there was the development of the first blood test for that diagnosis, PKU. And shortly thereafter, there began to be mandated newborn screening for that one diagnosis. Over time, the number of diagnoses did increase. And then in the late 1990s, right around when I was starting my career in metabolic disease, a new testing method called tandem mass spectrometry dramatically expanded the number of diagnoses that we could screen for on newborn screening. So what is the process for newborn screening and what are the guidelines? So newborn screening in the United States, it generally happens between 24 to 48 hours, and it screens more than 4 million babies born every year. And about 1 in 300 of those newborns does have a detectable condition identified through newborn screening. And there are 3 components to this. The first component is blood spot screening. That's where the team at the birthing hospital will take a small drop of blood from the baby's heel, put it on a special paper, and send it to a laboratory for analysis. And that's the category that MPS falls under. Other aspects of newborn screening include heart screening to look for congenital heart defects, and then hearing screening. And both of those happen in the hospital, and you can see the babies actually having them done here in these pictures. So as I mentioned, MPS lives under the umbrella of the blood spot or metabolic screening. So this is an example of an iteration of the newborn screening card in North Carolina. So you'll see that those circles in the bottom are actually filter paper, kind of like you might put in a coffee machine. And they absorb the blood from the heel of the baby. And that is sent to the North Carolina State Laboratory of Public Health here in this state. And in other states, there are similar entities that do this type of testing. There is a process involved with the newborn screening. So the hospital collects a blood spot and it's sent to the lab for testing. The screening is done in the laboratory, and the pediatrician receives the results and informs parents about any testing that is abnormal. If there's any testing that is abnormal on the newborn screening, then the family proceeds to diagnostic testing, where the baby may have additional testing to confirm or rule out the diagnosis of concern. Once that is completed for any children receiving a diagnosis, they'll then in turn be referred to specialists who can manage care and initiate treatment as appropriate. If a baby is not yet discharged from the hospital, they will still receive newborn screening, and those results will be conveyed to the care team that's at the hospital where the baby is. So newborn screening is a state-based public health program. So it is not a federal program, and it does vary from state to state. And each state decides which disorders will be added to their program. Currently in the United States, most states screen for about 30 to 40 diagnoses. And when states are determining what diagnoses will be included in their newborn screening, there are a number of factors they consider, including state laws, the cost of the screening, the frequency that diagnosis might be seen in their state, the availability of treatments and follow-up, and the funding sources that they have for the newborn screening program. So because there can be differences from state to state, in 2007, a group of individuals got together and created what's called the Recommended Uniform Screening Panel, or RUSP. And that RUSP is something that is published and available at the national level, and it makes recommendations based on evidence about what diagnoses should ideally be included in a state newborn screening program. Shortly thereafter, in 2010, the RUSP was adopted as the nation's standard for newborn screening. And more recently, in the 2010s to 2020s, states began to have alignment with the RUSP, whereby they thought about the RUSP and decided that their state should align with those recommendations. So it's not a federal program, but there is guidance available to states to make sure there's not disparities between states. So As I mentioned, in 2010, the RUSP was adopted as the nation's standard for newborn screening, and the guidance for the RUSP was provided by the Advisories Committee on Heritable Disorders and Genetic Diseases in Infants and Children, which was directed by the Secretary of Health and Human Services. Recently, in April of this year, the Department of Health and Human Services terminated the actions of this committee. Now, what did this committee do? They had guidelines for how to add a disorder to the RUSP. They wanted it considered serious and well described, where there was reliable testing available, effective treatment is available, and there was some data available about that particular diagnosis in some states. So most states and territories do screen for the majority of the RUSP conditions, and several states, including the one I'm in, have legislation in their states that says they must have alignment with the RUSP within a certain time period. So if a diagnosis were to be added to the RUSP, then the state would need to be mandated to screen for that diagnosis within a certain time period. So here on this map, you'll see the states with stars do have alignment legislation requiring to align with the RUSP. Some states also elect to screen for additional conditions beyond what is offered on the RUSP. So the current landscape of newborn screening is a little tricky right now. So with the dissolution of that advisory council, there is no national guidance on newborn screening right now. And much like before the creation of that group, this can potentially lead to increased disparities of newborn screening practices across the US. So patient advocacy groups now lack a clear pathway to advancing a new condition. Previously, if a group felt as though their particular condition may be an appropriate candidate for the RUSP, they had one group to go to provide information and evidence to. So with this current vacuum in that space, it's possible that states will likely need to develop their own advisory mechanisms to make those decisions. But most states don't have the kind of resources to perform in-depth evidence-based reviews on a case-by-case basis like the Secretary's Advisory Council does. There are efforts underway to sustain and improve these practices. So the American College of Medical Genetics and Genomics is moving forward with trying to create a new advisory framework to fill that gap. And the National Academy of Science, Engineering, and Medicine released a report in May, just shortly thereafter the dissolution of this council, emphasizing the need for national leadership and coordination related to newborn screening. So while PKU was the diagnosis that sort of originated newborn screening, this is a list of the current conditions that are targets, core conditions, meaning they are the primary target of newborn screening. And there are a number of different categories, and MPSs fall under the other category, but they have been MPS 2, you can see the dates of when diagnoses were added to the RUSP. So MPS 2 is one of the most recent additions to the RUSP. So the RUSP has evolved over time, and we don't know where the future's headed. In 1960, there was one diagnosis, and in 2025, there are 38 diagnoses. And new technologies, specifically genomic sequencing, looks directly at the genetic code, definitely has opportunity to expand newborn screening beyond the current targets, including the addition of a number of lysosomal storage diseases, including MPSs. So that's the overview of just newborn screening in general. Let's talk a little more specifically about newborn screening for MPS. What is the process? What are the successes and challenges of newborn screening for MPS? So let's think a little bit about MPS. It definitely meets the criteria that have been established for including a diagnosis in newborn screening. They're serious, well-described diagnoses, and a screening process is valid and reasonable. There are treatments available for MPS 1, 2, 4A, 6, and 7, and investigational therapies are being explored for a number of the MPS 3s. There is evidence showing that treatment initiated prior to clinical recognition is beneficial. If you treat a baby before they have severe symptoms, it makes a difference. And there are states that provide pilot data. So Missouri supported the addition of MPS 1 to the RUSP, and Missouri and Illinois supported the addition of MPS 2 to the RUSP. The goal is to allow for early initiation of treatment before irreversible damages occur. It also allows you to track over time patients, neurocognitive testing, and identify potential participants for clinical trials before they have very severe symptoms. Finally, genetic counseling, like what I do, allows the family to have more information to make informed future reproductive decisions. If you know a child in your family has a diagnosis, it allows you to come from a place of empowerment to make the best choice for your family if you'd like to expand your family. So MPS 1 was added to the RUSP in 2016, and here's a recent map of the United States showing states in purple where MPS 1 is included in their newborn screening. MPS 2 was a more recent addition to the RUSP in 2022, and you'll see that the map is a little less populated, although you'll notice that there are some states here with yellow stars. Those are states that do have RUSP alignment legislation, and they are required to include diagnoses that have been added to the RUSP to their state newborn screening within a certain time period. So if we were to look at this map and populate it in the next couple of years, you will start to see that purple get more broadly covering the state in the United States for MPS 2 in addition to MPS 1. So when we begin to think about newborn screening for MPS, we want to assess the relevant enzyme on the dried blood spot, that spot of blood on the filter paper that was collected at the birthing hospital. And for MPS 1, that's alpha L iduronidase, and for MPS 2, it is iduronate 2 sulfatase. See, this is where Kristen would have been better than I. She's better at naming these enzymes. And there are two primary methods for looking at this enzyme activity. Some use the technology called tandem mass spectrometry that was introduced into newborn screening in the late 1990s, and others use a different system called digital microfluidic or fluorometric assays. And the implementation of what you do next after you measure that enzyme is really variable. One of the reasons that people talk about what we say is second-tier testing is we want to reduce the number of people who are told, hey, your child might have MPS 1 or MPS 2, and then after you do subsequent diagnostic testing, that was not the case. Our goal is to capture and identify all children that have the diagnosis, but not identify many extra children where you have to then walk through that process with families. It can be a challenging space, and for those of you who had a child identified through newborn screening, you may recall that space when you were walking through it. So pseudodeficiencies for MPS. I apologize for not having heard all the other talks, but pseudodeficiencies are common in MPS. When we talk about a pseudodeficiency, it means that the enzyme level in the lab looks low, but GAGs are typically normal, although there might be minimal elevations present. But in the person, the enzyme activity is appropriate, and someone who has a pseudodeficiency will not have MPS, and they do not warrant long-term clinical monitoring. So in MPS, there is actually a common pseudodeficiency in Black or African American individuals, about 3 to 4%, but it does occur in all racial and ethnic groups. Many common pseudodeficiency genetic variants are known. So if we were to see a genetic result, we would know that that particular genetic result was associated with a pseudodeficiency. But over time, unique variants that have never been seen before that cause pseudodeficiency have been identified and are identified. So let's talk a little bit about how the newborn screening lab proceeds with screening for MPS. So the first thing they do is screen for the enzyme, but the subsequent follow-up testing vary from state to state, and not all states do the same thing. So state number 1 may do enzymatic testing and then report anyone who has deficient enzyme level as having a positive newborn screen requiring follow-up, and then refer that individual to genetics where they proceed with diagnostic testing. So doing genetic testing or DNA testing, looking at GAGs, and looking again at the enzyme. Because pseudodeficiencies are so common, especially in MPS 1, the majority of states that follow this protocol will have the majority of their positive newborn screens being false positives, meaning the child does not have the diagnosis. This type of protocol causes significant follow-up burden for the team that works with families and undue anxiety for the team, for families. Because of this, most states and territories use a second-tier approach where they do other testing after enzyme testing to reduce the number of false positives in their state. So another mechanism in state 2, they might offer a second-tier test where after a reduced enzyme activity is identified, the dried blood spot is actually sent for gene-specific genetic testing to look and identify if there are any changes in that genetic code. Sometimes that's normal, where no genetic changes or variants are identified, and sometimes they may see genetic changes of pathogenic or likely pathogenic, or sometimes a variant of uncertain significance in the gene. And in those cases where there is a change in the gene, then the individuals will be referred for diagnostic testing, including repeat enzyme testing and GAGs. This method reduces the number of false positives, so reduces the number of individuals who are identified and don't have the diagnosis. But individuals who have genetic changes where we don't completely understand them still is a big challenge in this sort of order. So there are variants that have conflicting interpretation. We do our best to understand genetic changes, and when we see the same genetic change, so if this gene sentence is misspelled the same way over and over again, we know a lot about it. But there are some variants who may have conflicting interpretation. One laboratory may say, we think this genetic change is associated with diagnoses. Another laboratory may say, we're not certain if this genetic change is associated with diagnoses. And in MPS 2, for example, 60% of patients who are ultimately diagnosed with MPS 2 have a private, meaning private to their family, not broadly seen in the population, have private variants, making interpretation very challenging. Additionally, not all genetic testing is created equal. There are some types of genetic changes that are not easily recognized on what we call gene sequencing, where we sort of start at the beginning of the sentence and read till the end of the sentence. And the genetic instruction is rearranged in some way or missing in certain areas. And those are associated with severe symptoms, but are not always easily identifiable on the type of genetic testing that is often offered through newborn screening called sequencing. So the third option in second-tier testing is to go ahead and send the newborn screening blood spots, the same one used for enzyme testing, to evaluate whether or not the GAGs are elevated, and look to see what happens for individuals who have elevated GAGs. So doing GAGs first as opposed to genetic testing. So you'll see in this panel, diagnostic testing includes DNA testing. And in this scenario, most of the positive newborn screens are likely to be a true diagnosis of MPS. So again, minimizing the workforce burden and also minimizing identification of families who ultimately will not have the diagnosis of MPS, but at the same time, maximizing the identification of children who do have a true diagnosis and will benefit from earlier intervention and evaluation. So the preferred method of newborn screening for MPS is first tier testing is enzymatic activity, looking at the enzyme. Second tier testing is looking at urinary gags or biomarkers or blood biomarkers if it's done by the state, blood gags. And then third tier testing is genetic testing, DNA sequencing or genotyping. So the ideal follow-up protocol for MPS is that you identify a result that has decreased enzyme. You send that enzyme for dried blood spot gag analysis. If that is still abnormal, that's considered a positive newborn screen, and the pediatrician and the MPS specialist communicate with the family to move forward with next steps. In North Carolina, we do proceed with genetic testing, but that may take a little bit longer to complete than the abnormal gag analysis. So sometimes there's a delay for that final test. It's in process, but we do want to work with families during that time period. So we work with geneticists and genetic counseling to pursue diagnostic testing, and we will do enzyme testing and urine gags, and determine whether or not this is a confirmed diagnosis for the family. So it's a multi-step process. For clinical follow-up, infants with severe MPS 1 or severe MPS 2 consistently demonstrate elevated gags following their positive newborn screen. And most attenuated cases also have elevated gags at birth. But there are some cases where the gags may be borderline or only mildly elevated. And those cases are ones where you want to closely monitor and follow up that baby to determine if there's sufficient evidence to indicate that child does have clinical symptoms or doesn't have clinical symptoms. The treatment of MPS 1 is guided by disease severity. So for severe disease, transplant is recommended, and ERT or enzyme replacement therapy may be initiated prior to transplant. And for the attenuated phenotype, enzyme replacement therapy is recommended. And for patients where we're uncertain about phenotype, enzyme replacement therapy is recommended, as well as close clinical follow-up as needed. For MPS 2, ERT is the recommended treatment. Transplant can be considered, but is rarely advised due to the variable outcomes. And for the severe phenotype, treatment should begin immediately. And for attenuated phenotype, early initiation of enzyme replacement therapy is recommended, but it really is a conversation between the family and the provider. And for an unknown phenotype, where we're uncertain whether or not the patient will develop symptoms, ERT is recommended, close clinical follow-up is needed, and there may be additional ways to get more evidence for a family. Because of the way MPS is inheritance, because it's an X-linked diagnosis, sometimes we can work outward from the baby who's been identified as having an abnormal newborn screen and test other people in the family who may provide us additional information about whether or not perhaps a grandfather, a maternal grandfather, for example, may have the same variant as identified in the infant, and that might be very reassuring to the family and the clinician. There are a lot of resources available for providers related to newborn screening for MPS. So the American College of Medical Genetics and Genomics has ACT sheets where they specifically provide information about what the diagnosis of concern is and what next steps should happen. They have videos called knowledge nuggets that are really actually kind of fun to watch, that do provide additional information for families. And there's this really lovely communication sheet was created by the Secretary's Advisory Council that worked on the RUSP, talking about how to guide physicians to talk about positive newborn screening results to families. So generally in the state of North Carolina, We do communicate with that baby's provider, and oftentimes it is the provider who is sharing the positive newborn screening results with the family in advance of the MPS center ever interacting with that family. And this gives some nice guidance for inexperienced providers to talk through that with the family. There are also really lovely resources for families that can provide some information. The example on the right here, the North Carolina Newborn Screening Program created a fact sheet for parents. Many states in the US have fact sheets available from their public health program that review and provide targeted information designed for families to share information about what a positive newborn screening result means and what the diagnosis is. There's also some really great family stories that can provide some perspective for families. And there are other resources. The MPS Center is one of them. Also, the National MPS Society and HRSA, or the Health Resources and Service Administration, has a website related to newborn screening that reviews newborn screening on a diagnosis basis. So they have specific pages for diagnoses included in newborn screening presently. So let's think about before a diagnosis before MPS was included in newborn screening, what that looked like for families. So the diagnostic odyssey without newborn screening is that family members or providers begin to notice symptoms. And generally, it's about a half of a year before there's a first medical contact where people talk through those symptoms. And it often can take 3, almost 4 years to get a referral to a center of expertise, and more than 4.5 years to get a confirmed diagnosis. So in many cases, there were about at least 8 healthcare professionals that were consulted, and many children received misdiagnoses the first time they received a diagnosis. So what they thought they were told their child had was not actually the diagnosis their child had. What newborn screening does is it allows us to avoid that diagnostic odyssey that's experienced by many patients and families. So newborn screening happens at birth, and a confirmed diagnosis for a child diagnosed through newborn screening generally happens before the baby is 2 months old. And that allows you to be proactive as a care team and as a family, and allows you to access that critical window when there's the greatest benefit for initiating therapy to kind of change the lifelong trajectory for a child. So I mentioned earlier my colleague Kristen Kleinert, whose slides these are, and so she has the direct experience with Ben, but I wanted to keep these pictures in there because they're amazing. But Ben was a child who was identified during the North Carolina pilot program for MPS 2. And so he is someone that is on treatment and started at treatment at 3 months. So because he was in the pilot program, he was diagnosed a little bit later than typically for newborn screening now. So he was diagnosed at about 7 weeks of age. But there are some challenges related to his story. He did have reduced enzyme activity, and he had GAG analysis. But when we looked at his genetic code, he has a private variant. And so the question is he asymptomatic? Does he have very mild clinical features? What's going to be the story for this baby? So there are definitely challenges to doing newborn screening for MPS. There is no reliable biomarker to determine the severity. So we can tell someone, yes, it looks as though they might have MPS, but determining the severity is challenging. So right now, the genetic change is the only way for us to predict severity in an asymptomatic baby. But the relationship between genotype and phenotype is not completely understood, and there's a huge impact of novel missense variants that are difficult to interpret. Family cascade testing may give some clues, but is not always informative, or there's not always members of the family that would give us the information we need. And variant classification differs from laboratory to laboratory. So there is some subjectiveness to how a variant may be interpreted from between labs. There is also a lack of guidelines on treatment initiation and how to monitor for attenuated phenotypes. So there's variable disease progression, and that means variability in the recommendations that providers make. And there's discretion and conversation between the physician and the family related to the timing and initiation of enzyme replacement therapy, for example. And some families may make a different decision provided with the same information. There also is a lack of robust tools for monitoring and guiding the management, especially for these attenuated phenotypes. And we put families in a difficult situation when we are uncertain about what this really means for their child. When newborn screening is reported as positive, there is distress and anxiety awaiting those confirmatory results. And a place of uncertainty is a tough place to live. Families are grieving the child that they anticipated raising, and babies look typical. One of the beautiful things about newborn screening is you identify babies before they have symptoms. But one of the huge challenges of newborn screening is that the babies don't look sick. And so some families may be in denial of a diagnosis and refuse treatment, or have difficulty maintaining that relationship with the care team because their baby doesn't feel sick to them. And babies are too young to show the evidence of any cognitive or developmental delays. And so there can be a real disconnect between what you're telling a family about their child and what they're seeing in that infant in the room. So one of the reasons I walk through those different mechanisms for identifying children is that the goal is to lower the number of families who are identified and ultimately have a false positive result. So by using multi-tiered algorithms for multiple diagnoses, and for MPS, incorporating GAGs and molecular analysis allows us to lower the number of families that are being told this might be a diagnosis for their child, and also getting access to genetic counseling right at the onset of positive newborn screens. So Kristen, who's not here, actually very much talks to every family and walks through them with them through the process of getting an abnormal newborn screening result in North Carolina, and until that case is resolved in some sort of with a plan for the family, whether it's this was a false positive, or let's monitor, or this is a diagnosis, let's start treatment. And so critical things that influence how parents are going to do is how and what you communicate, as well as supporting them, acknowledging the challenges that come with receiving a result that is positive. The Munzer Center really has a family-centered approach. And so you can see here Dr. Munzer with Ben over his lifetime, and the whole team. The needs of the family are prioritized through the screening process. So it's not just the medical things, it's paying attention to what's going on with this family and giving them the resources they need to feel supported. So what more can be done? I talked a lot about MPS 1 and MPS 2. Those are not the only diagnoses that are considered MPSs. And so early detection can make a difference, and technical capabilities exist for all the other MPS disorders to include it in newborn screening. Right now, West Virginia is the only state screening for MPS 4 on standard newborn screening. But screening for other MPS disorders is being conducted through voluntary research studies. So Screen Plus offers multi-tiered testing for 14 additional diagnoses and includes multiple MPS ones. And it's available for babies born in a pilot hospital in New York. And efforts are underway for other MPS disorders outside the US. So MPS is on newborn screening in Taiwan for MPS 3, B, 4A, and 6. and pilot studies are being conducted in high-risk communities. And information that we learn from other countries and their screening programs can inform the decisions about screening in the United States. Genomic sequencing, and this is how I kind of dovetail into newborn screening. There are numerous voluntary newborn screening programs offering genomic sequencing as a first-tier test. In North Carolina, Early Check, which is currently on pause, included MPS 1, 2, 3A, 4A, 6, and 7. And there are other similar programs around the country. I've listed just a few, but there are multiple studies around the world that are studying this genetic testing first approach to doing newborn screening. And additionally, in North Carolina, at UNC, there's an age-based genomic screening approach to public health where you offer screening at an appropriate age for the child. So not newborn screening, but maybe at age 5, for example. So in summary, newborn screening is a state-based public health program. The recommended uniform screening panel serves as a guideline, and right now only MPS 1 and MPS 2 are currently included on the RUSP. There is no longer that National Advisory Committee for evidence-based review of new conditions. Although the benefits are clear, there are definitely challenges, including pseudodeficiency and testing severity prediction for babies and infants. But technical capabilities do exist for all other MPS disorders. The real heart of newborn screening is allowing for early detection, which allows for early initiation of treatment before clinical symptoms are often present, which can really meaningfully change the trajectory of a diagnosis for a baby. So proactive care instead of reactive care within a very critical time. So that's the end of my presentation. Thank you so much. And I believe there's some time for questions. I'm going to stop sharing my screen.
Thank you, Jennifer. Appreciate that you do the presentation on sort of a last minute notice. Just a couple comments for the audience that you didn't mention. I don't think you mentioned it, but West Virginia is currently screening for MPS 4A, the only state in the country to do that. And then I also saw in the chat, South Carolina will start MPS 2 newborn screening in early 2026. So thank you, South Carolina, for that comment. I just want to say in North Carolina, we screen, as you heard, for both MPS 1 and 2 as part of the newborn screening program. We're currently using the Revity endogenous non-reducing ends, as you may heard early on was from Tim Wood. That is our sort of second tier along with DNA analysis. But if we see a negative non-reducing end that is a normal sample, then those families are really never identified. And so we're not getting a lot of false positives. All the pseudodeficiencies are basically not being identified. So that's sort of just some perspective. I think, Jennifer, for me, one of the challenges that you appreciate is either rare disorders, and the local physician sometimes doesn't have a lot of expertise. You showed something very briefly of things they could do, but maybe just comment on some of those things the physician can do to help make their families have more comfortable being identified with having an abnormal screen.
So I think some of the things that we try to work closely with physicians to do is to provide them the resources they need. So I put up some pictures of resources created by the state of North Carolina. They create both resources for providers and for families. And so giving primary care providers information in advance of them working to communicate to families and making sure that they're aware of the resources available. So one of the helpful things in North Carolina is that we can talk about the presence at the MPS Center, but there are expert clinicians throughout the country that can help provide some perspective for a primary care provider that might never have I've seen a patient with this diagnosis before. So that's absolutely something that is really helpful and valuable, knowing that they have resources.
Jennifer, the question that just came in, and I may answer it, but I want to at least read and let you first tackle it. I apologize if I missed it, but are are they recommending ERT for babies with MPS 2 after a positive newborn screen when they're being identified?
So I think the initiation of enzyme replacement therapy is very patient specific. And so it's not a one size fits all. Dr. Munzer, I know your expertise is better in answering that question than mine.
No, I think your comment is these are patient specific, depending on what happened that you allude to, sometimes with family testing, we identify an uncle or a grandfather who had that same variant. And in those situations, we may not do anything if that individual has very mild disease and wait for clinical disease. So it's not like just because you have a positive newborn screen that you should immediately treat ERT. A lot of circumstances you maybe should, but there are some variants that may not present till later. And my recommendation would be to wait maybe for clinical disease. Don't treat initially if that turned out to be a very late or attenuated disorder. But each patient has to be treated individually, as Jennifer uh, recommended. So the next question is, thanks so much for your presentation. Appreciate it. Appreciate it as someone with MPS 1, her or Shay, more her symptoms, but intellectually more severe Shay. But my gags don't stop production. Maybe the gags don't drop production after being bone marrow transplant. I'm not sure exactly the question. I guess that's more of a statement I'll hear. But my gags don't stop or don't drop production after even BMT at age 10 when ERT didn't work after being diagnosed late age. That's challenging. I won't let Jennifer answer that. I'm just going to let sort of comment about that. I think that's a question where I need to see a lot more detail because again, typically ERT does result in decreased GAG. They don't normalize, but there may be issues of antibodies or other issues. And that's a question that I think the MPS Center would be happy to help families, as Kristen and I are just sort of put in the chat. Thank you, Kristen. MPS Family Center is happy to help providers and families navigate MPS results and assist in determining the best monitoring treatment plans. So please contact us, or contact your other provider to get information. These are individual, sometimes decisions, lots of challenges. The history is so important to what we do. So with that, thank you very much, Jennifer.